So I've been asked to speak on neurodevelopmental disorders, and I apologize to my other co-speakers to jump the order. Now, neurodevelopmental disorders are really a group of conditions where the onset is in the developmental period, and they are essentially there are deficits that produce impairment of function. And the new DSM-5 criteria has clubbed a large group of disorders within this cohort. These include intellectual disability, communication disorders, autism spectrum disorder, ADHD, neurodevelopmental motor disorders, including tic disorders, and other specific learning disorders. So it's a very broad concept, and in some situations, they even include cerebral palsy and epilepsy within them. So essentially, they are characterized by deficits in cognition, language, behavior, with or without motor skills. And these cause impairment of personal, social, academic, and occupational functioning. So because it's a huge group, they are clinically and etiologically very heterogeneous. Their manifestations are also related to altered neural development. And because they are essentially in the developmental phase of life, they would present in infancy, childhood, and early adolescence. Typically, these disorders are not progressive. They are non-progressive disorders, though along with maturation, we will get some changes. And they follow a relatively steady trajectory, and they don't have a relapsing and a remitting course like some of the metabolic disorders. So like I said, the etiology is extremely heterogeneous, and we'll see this little data on that. We know that this is a publication from India. The estimated prevalence in India varies from 3 to 13%. 50% of these are not non-genetic, and due to these various causes that are enumerated here. However, the balance 50% are genetic, which I'm going to touch upon. And these would include the categories. For some reason, it's not come up. I think it's the milk from the apple and all. So these include chromosomal disorders, monogenic disorders, metabolic disorders, Fragile X Rett syndrome. And there is this 30% which remains undiagnosed despite all the conventional tests of karyotype, metabolic testing, chromosomal microarray, MLPA fish, as well as some common single gene disorders, as you can see here. So for these 30% disorders, we do the newer test, which is the next generation sequencing. So how do we approach to a diagnosis? Because you can see here that there are a vast array of technologies that can be used. So how do you decide what technologies to be used? So as for any case in medicine, it starts with the history. And here in genetics, the medical of the development history, the 3-generation pedigree, antenatal history become very, very relevant to take into details of other affected members in the family and consanguinity. We also put a lot of importance to looking at photographs. We never click a photograph without taking a signed informed consent. And at times, you also need to look at photographs at different ages because that can give a clue because of changing phenotypes with age. And of course, a maternal history of pregnancy losses, abnormal antenatal findings, etc., can also lead to a clue for the clinical examination. And after we are done with that, a systemic head-to-toe clinical examination that is detailed and very precise becomes relevant. So this is just an example of a very informative family history where there are 2 males who are affected and have intellectual disability, and they are 2 females. And there is a history of early menopause in all these women who are starved. And if you put everything together, you would think of an X-linked disorder, which has a variable manifestations. It has premature ovarian failure in women and intellectual disability in boys. And this is the Fragile X, mental retardation syndrome, which is an X-linked phenotype. So just with this very, very simple and detailed history, laying down your pedigree, you don't need to go through the plethora of tests, but just order the Fragile X TP-PCR. Okay? It's a triple repeat disorder. So Sango will not pick it up, microarray will not pick it up, exome sequencing, which is, the new kid on the block, will not pick it up, but you need to order the specific TP-PCR. Now, the other clues to diagnosis include, a core species, you go into this group of disorders. If there are skin abnormalities, you would think of this group of disorders, etc. And just to give you a clue as to how we make diagnosis by the bedside is three children with neurodevelopmental disorder, one having some subtle facial dysmorphism with hepatic involvement. And look at the hair, it is so abnormal. And if you pluck it and see it under a light or a microscope, you find the trichohexis nodosa and the abnormality. Now here there is a blonde sort of a silvery copper hair along with seizures and neurological disorder. This is mentally stinky hair syndrome. Whereas here, this is Grisely syndrome that is associated with neurological and hematological findings. So this just gives you a clue and you go ahead and do this. In fact, for this child, this was in the era before NGS, and we went back into literature, read about it. I identified a sort of a common mutation that was reported in the Indian population and tested that in this child, and we were able to make a diagnosis with a simple PCR-based test. So remember, for everything, you don't need high-end technology, but you just need to code it. So how do we approach to testing in this very heterogeneous population? You suspect a disorder and you do the appropriate investigation for that disorder, the two cases that I've already alluded to. However, more often than not, we do not have a specific syndrome that is recognized, and then you have to follow a sequence of evaluation. So first you do other functional tests, which would involve assessing hearing, looking at the vision, looking at the MRI, doing an eye examination to give you clues. And based on that, and especially thyroid in our status, because we don't have universal newborn screening, in any neurodevelopmental disorder, you look at thyroid. And you do some tests like vitamin B12 deficiency that is common. You look for iron deficiency. So these are the basic things that you need to look for before you go into specific genetic testing, which I'll be talking. And then within this group, you decide, is it going towards a metabolic disorder, chromosomal disorder, or a monogenic disorder, and then appropriately take forward the testing. I'm just going to illustrate all this through a couple of examples. So this was a 1-year-old child who came with developmental delay and had only achieved head holding. The seizures were there. There was hypotonia. The child was very fair, much fairer than his parents, and had light colored hair. We looked at the MRI and that showed some subtle abnormalities in the form of dilatation of the perisylvian fissures, and there were prominent subarachnoid spaces. So with this, we went ahead and did our basic metabolic screening, because when you have seizures, developmental delay with a child who's very fair, we really want to exclude 3Ku. We do the tandem mass spectrometry. There is high levels of phenylalanine. You check the urine organic acid by GCMS. And once you have a metabolic diagnosis of phenylalanine or phenylketonuria, which is, you get the diagnosis because of the high Phe levels. You do the gene sequencing to check the variant in the genes. Now, a high Phe level can also be associated with other disorders of the pterin pathway. And we have additional pterin tests, etc., but those are not available. So we rely on the sequencing. Now, this was done by NGS because then you can cover the entire panel of disorders that cause abnormalities of pterin as well as phenylketonuria. And what is the relevance of this testing? Because there is very, very specific treatment for this. And the earlier we initiate a low protein diet, remove the offending amino acid, which is phenylalanine, and keep the child on stringent follow-up, they would do well. On the other hand, we had this child again who presented non-specifically with global developmental delay. He was very self-absorbed. He was happy. We actually thought it was Angelman syndrome, but the test came back as positive, and the test you do for that is a methylation specific NLP. But that was negative. And the MRI was normal, but it was later when we didn't get any clue. We looked at the MRS. It should be done routinely, but we don't do it routinely because of cost issues. But this is a great test because it gives you the diagnosis at one go. There is an abnormal creatine peak. So this is a cerebral creatine deficiency disorder. Now, once you've got this clinical diagnosis, you start the patient on creatine supplementation, which is again started early. It works well. And then do an exome or a clinical exome, because there are 3 genes within this pathway of creatine deficiency syndromes, which can be difficult to differentiate phenotypically. So you would need to test all three genes to identify what your patient had. And in this case, it was a biallelic disorder, homozygous mutation, because it's an autosomal recessive disorder in the GAMT gene. So these are different ways you decide as to what are you looking at. So even if you don't know what you're looking at, I mean, we could say that from here I could just go to NGS, but NGS brings up so many variants. So if you know what you're looking for, it's easy to identify the needle in the haystack. So for this group of disorders, the most relevant and important are the metabolic disorders because these are the treatable intellectual disabilities. And this group has worked a lot on creating a two-tiered approach, so you don't have to do a large number of tests. But these are basic tests that need to be done in most children with intellectual disability. And these include ammonia lactate, the plasma amino acid, which you can really get by NSMS analysis, because in addition to giving you acyl carnitine, that also looks at the amino acids. And homocysteine is very relevant because cobalamin deficiency, homocystinuria, MTHFR deficiency are not so uncommon in our country. And all three of them are very, very easily treatable with good outcomes. And then in the urine, you look at GAGs if you have coarse facies or oligosaccharides. Otherwise, for the small molecule disorders, you do a GCMs. And then beyond, if you get something or you've got a real clue that this belongs either to a mitochondrial pathway or it belongs to a peroxisomal pathway, you do additional tests, but this is not at tier 1. So when you have a child like this, and we all recognize this to be Down syndrome, again, you need to do something like a karyotype. Despite it being a clinical diagnosis, a karyotype becomes very important to differentiate pre-trisomy 21 from translocation Down syndrome, where there is a risk of recurrence like you see in this family, to a mosaic Down syndrome, where the phenotype would be much milder. But you can see in all the kinds of abnormalities, the children all look the same. So what are the indications beyond Down syndrome to perform a karyotype? If you have a characteristic phenotype, say trisomy 13, trisomy 18, or Turner syndrome, growth retardation, developmental delay or intellectual disability, dysmorphism, and malformations. A conventional karyotype, it's still not out of the box, gives you a diagnosis in about 3 to 15% of cases. And the biggest advantage is it's cheap, though it's labor intensive, but it also identifies balanced translocation, especially where you have positive family history of recurrent pregnancy loss or other children who have intellectual disability. The second technology we use for chromosomal disorders is when you look at a patient, you've seen a similar patient before, it's there in your hindsight, and then you make a gestalt diagnosis. For example, with this boy, he was actually quite old. He had not been diagnosed till about 20 years of age. We went ahead, we made a clinical diagnosis of Smith-Magenis syndrome, and then went ahead to do a cheaper technology than microarray, which was the MLPA. We used an MLPA group set where they were able to diagnose Smith-Magenis syndrome, where you can see there is this heterozygous deletion on MLPA. So this is how various technologies are used. Whereas on the other hand, you can have a phenotype like this, which is a little non-specific. Looks different, definitely, because of the facial profile. There's developmental delay, there's hypotonia. It doesn't fit a syndrome. At least we had not seen a syndrome that fitted into this. So we did a chromosomal microarray to identify this deletion in chromosome 9, which is the 9234 microdeletion syndrome or Kleefstra syndrome. So where we don't have a specific diagnosis, the advantage of microarray is it identifies smaller changes, which could be microdeletions or duplications that are not picked up by the karyotype in the chromosomes. And the diagnostic yield of microarray in intellectual disability on an average is about 15 to 20%, with variable percentages depending if it is isolated ID or ID associated with other findings like microcephaly or seizures or malformations. So the advantages of microarray over a karyotype is its greater resolution. It is less labor intensive. It does not require dividing cells, so you don't have to set up a culture. But there are conditions that it does not identify, and that's important to know. Sorry. Polyploidy is balanced translocation, very low level mosaicism. But I think more than anything else, the biggest challenge for microarray, because it is very extensively used these days, is analyzing the variants of unknown significance and counseling for these. It is still a challenge in my unit after using array for so long because every variant is different and to counsel the family of the significance of this. Then we come to that 30% I showed you in the initial pie diagram, where all those technologies have not given us a diagnostic view. And within that, we did this study in about 227 children with intellectual disability. My DNB student, Dr. Sapna, who just finished her work, we used in children without a diagnosis on a basic metabolic screening and a normal chromosomal microarray or karyotype. We used next generation sequencing using either technology, either whole exome sequencing, clinical exome, trio exome, and in one or a whole genome. And here the diagnostic yield was about 53.7%. This was over a period of 3 years. So what was the pattern that we identified? So we only took pathogenic and likely pathogenic variants. We did not use goose variants, which we were not able to reclassify. And it was as heterogeneous as finding abnormalities in 84 intellectual disability genes. And sorry for this, I think the transition has caused all these changes. But most of them, what we found more common was autosomal recessive intellectual disability, unlike Western literature, where autosomal dominant intellectual disability is irrelevant. And the importance of this goes in counseling. So what is the impact of diagnosis on management? So what if we've made a diagnosis of intellectual disability? Our age-old conception is that we can't do anything for the child. But it's interesting to note the amount of impact it's had. One is active clinical management, either related to epileptic encephalopathies or related to metabolic disorders. Now, there is some form of treatment for Fragile X syndrome. You have management for Loeys syndrome, hyperreflexia, Leishman syndrome, etc. Long-term clinical management, you give surveillance guidelines to patients who are identified to have, say, like Keaton-Cowden syndrome or other disorders, where you have to follow those patients up for malignancies and other things. Reproductive focus outcomes, of course, becomes very relevant because, like I told you, a large percentage of the disorders we identified were autosomal recessive. They have a 25% risk of recurrence, and prenatal testing is only possible if we have a definite diagnosis in these families. And then, of course, we have family-focused outcomes where extended family members are affected. So now the next thing is that it's not as if in all the undiagnosed cohort, we identified abnormalities by exome, because exome sequencing does not answer all our questions. Because there are large rearrangements, copy number changes. If the mitochondrial genome is not covered, a large number of applications now cover the mitochondrial genomes, mosaic phenotypes, triple repeats, uniparental disomy, or mutations where there are highly repetitive regions or GC-rich regions, or where there are pseudogenes or very homologous sequences. So there are a large number of limitations which we can enumerate for exome sequencing. So what do? Do we take it forward, and do we think genome sequencing is going to do that? So for the last 2 years, 3 centers in our country have been working on a Indian Undiagnosed Diseases Program project, where we are predominantly using genome sequencing. And we now realize even that does not answer all our questions. It has great advantages of universal coverage to detect copy number variations, to go and identify deep intronic variants. But the challenges you can see here are immense. And this is one case that we solved using genome, where exome did not give us answer. And there was this girl with intellectual disability and severe intellectual disability, microcephaly, and visual problems. And the mother had come in pregnancy, and this is exactly how they come. However, we did first an exome for the child, then we did a trio exome, By that time, the pregnancy had advanced, there was microcephaly, and we had a 4-year diagnostic odyssey, but it did not find an answer for the family until we did a genome sequencing. And you can appreciate here the universal coverage there is here. And we identified 2 deletions, one large one which could not have been picked up by exome sequencing, that gave an answer that was consistent with the phenotype. And this is in the TUB GCP6 gene. So therefore, using all the genomic technologies, this is a large meta-analysis, not only for ID, but for most genetic disorders, but predominantly neurodevelopmental disorders are the ones that are there. And you can see that between exome sequencing and genome, there's hardly a jump of about 5%. So there is still a lot we don't understand. We need to go on to transcriptomics and epigenetics, etc. So it's a long journey ahead. And just before I conclude, this is the Undiagnosed Diseases Program, which all physicians can enroll their patients in who have a long diagnostic odyssey. And this is the email where you can communicate, and it will be transferred to any of the 3 centers who are involved in this program, which is Gangaram Hospital, SGPGI Lucknow, NIMS, and CDFT Hyderabad. Thank you very much.